Hello everyone, welcome back to my YouTube channel. I'm Aarushi, a third year dermatology resident. So I'm going to talk about a very important topic, that is the kind of deaths that I saw in my residency as a dermatology resident, and what all did I learn from it. And if you guys have any suggestions, any comments, to write down in the comment box below. So this is a very unusual video. I hope it does not strike any controversies or something like that. But yeah. So I think one of the major things that happens in a dermatology ward is that most of these patients have peeling of their skin. Now when your skin has peeled off, it has a tendency to stick to the bedding. When your skin or the blisters that have peeled off, they stick to the bedding. So what happens is when patients lie down, they have a very difficult time getting up. Okay, so most of these patients have a tendency to eat and drink while they are still lying down. तो उससे क्या होगा? Most of these patients aspirate. So I have seen 3-4 deaths due to aspiration. Mostly what will happen is they give the history that they had food, and 30-20 minutes later the patient started having breathlessness. So we have not been able to save any of these people, but once I saw one of them getting saved. So what we basically did in that case was SpO2, that patient's SpO2 started dropping. Okay, when the SpO2 started dropping, we started the patient on oxygen inhalation. Now in that inhaler only we gave some steroids. Okay, because when the patient aspirates, there would be inflammation. Okay, then we were suspecting bronchoconstriction, so we gave IV theophylline and stuff. Now one of the most important things that I always say that you should do is to send an ABG or a routine. That also we had sent, and if any necessary correction was needed, we did that. So the patient had to go to ICU, and she was given mechanical ventilation for a few days, but we could revive that patient. Another thing that I commonly see is when your skin is peeled off, the patients usually they have a very high tendency to get skin infections. Okay, sometimes these are resistant strains and we're not able to get the patient back. So one important thing that you should maintain around every patient with pemphigus or skin peeling is that they should be in a very hygienic environment. The caretakers should wash their hands thoroughly, and cleanliness should be maintained basically at each level. Another death that I think I saw was one pan patient. Again, she died because of a resistant strain, and also because one of the deaths that happened was a very young girl. She had dermatitis enteropathica, and she died because of very low potassium. So her potassium was 2.1. So but the thing was, her potassium was very low, her calcium was very low. So all dermatitis enteropathica, I think dermatology people should not try to manage, because we get it that there are some medicines that we need to give from derm side, but these people are overall very malnourished and they might have low potassium, low sodium, low calcium and stuff. So they'll need even better management than what we can provide. Besides that, I think another patient that I saw was a very interesting case. So this patient had typical features of SGSTEN, and when he came to the hospital 15 days prior to that, he had taken chemotherapy. Now after taking chemo, he had those typical prodromal symptoms. Not 15 days, I think even before that he took some chemotherapy. So he had typical prodromal features, and then he had conjunctival bleed and oral mucosal bleed, and I was like we were all like almost sure that this is SGSTEN. But in the morning, I had sent a sample for that patient, but the report came as non-recordable, which was very weird because that usually does not happen. But I think that happened because the platelet count was extremely low. In the morning, we sent another routine and the platelet count came as 1000. So when we were presenting the case during the rounds, my consultant said, see, this bleed is not very typical of SGSTN. I think this is methotrexate poisoning. So we googled the chemo that he had taken, and he had taken very heavy doses of methotrexate, and it indeed was methotrexate poisoning. So until and unless the patient was given filgrastim and leucovorin, we could not have saved him or her. But unfortunately, by the time the diagnosis and stuff was made, the patient had a massive bleed and we could not get the pulses and stuff, so we were not able to save the patient. Again, besides that, there was another patient for whom we were not able to make a diagnosis only. The patient had some malignancy. The malignancy had metastasized